Why do you think sepsis has taken over thromboembolism as the leading cause of maternal mortality in UK as per the CMAS 2011 report?
I think there are a number of reasons, but the most important, I think, is that thromboembolism about 4 years ago in the United Kingdom was taken very, very seriously, to the point that there was an Act of Parliament passed that two things will happen if anybody develops thromboembolism in hospital where no action has been taken to try and prevent it happening. The first is that the local area board would be responsible for the cost of that patient. Now, if you develop a DVT and you go on and develop for the rest of your life edema in your legs, for example, from the embolism, that health service will then be responsible, not the health service of the country, but the health service, what is known as a trust in the UK, will be responsible for treating your post-embolic, post-DVT for the rest of your life. You can imagine what the costs of these things are. And worse, if they got to court and it was found that the hospital had failed to fit you with DVT stockings, failed to give you heparin, failed to do any of those things, therefore that they would also be responsible for all legal costs at trust level, not at departmental level. So you can imagine what happened in the UK 4 years ago. We had 10, 15 nurses running around with clipboards every day. Every patient that came into hospital had a thromboprophylaxis assessment. They all had some sort of treatment given. Sometimes it was useless, like filling them up with stockings, for example, when it's inappropriate. But suddenly also a great amount of equipment became available to operating theatres in the form of calf compressors, in the form of heparin, in the form of Fandoparanux, in the form of clopidogrel and so on, so that all patients virtually now in a hospital in the UK receive some form of thromboprophylaxis. So I don't think it's been that sepsis has increased. I think that, that thrombosis has reduced.
No, so that would mean the stick of the money works. The second one, yes, that would be better. The second one is also for you, sir. How do you translate near-miss audit in a private or a solo practice?
Absolutely. This is a bit rough, you know. I keep getting all the questions here. No, I think, look, it's a very important question, I think, and it is relatively easy to do. And that is to, A, amalgamate resources with other things that are not part of your private practice. For example, we have invited the Prince of Wales Private Hospital upstairs and the Sydney Eye Hospital, which is a relatively smaller hospital, that lives, we've made them almost, for the purposes of near-miss reporting, part of our data and part of our hospital. So that basically, I think if I were a solo working in private practice, I would ensure that either I'm on a college program that does this sort of thing, or that I'm on the medico-legal and medical defense union reporting of this, or alternatively that I would join a bigger hospital in using their system and their data. After all, it costs them nothing to include my data onto theirs.
Right, sir. Now, the next one is for Williams, right? You can take a deep, nice breath. In a nutshell, what will be the future guidelines to reduce the maternal mortality rate in modular training of anesthesiologists? Could you have a couple of words?
Could you repeat the question, please?
In a nutshell, what will be the future guideline to reduce the maternal mortality in modular training of anesthesia trainees?
Well, this is a good question, and it's an important question. What can we do with our trainees? Well, several things. One thing, the good news is that really severe critical emergency events are very rare. So how do we train people to do something if the incidence is such a rare occurrence? Well, we have simulation training. We actually require that all of our trainees go to our simulator. We actually have in Boston something which is being replicated around the world, which is an obstetric-specific simulator, where we have personnel that are working on developing obstetric-specific protocols and scenarios in the obstetric-specific simulator. And it's not just anesthetic trainees, but we have our obstetric trainees, and we also have our nurses and our midwives that go to these simulator sessions where they have obstetric-specific scenarios. So it doesn't include just anesthesia issues such as failed airway and hemorrhage and things of that nature, but includes obstetric issues such as shoulder dystocia, difficult deliveries, difficult ethical issues, a whole variety of things like that. So we actually require that all of our trainees go to these simulator sessions. Now, another thing related to training is that we all love to do regional anesthesia. The problem is it's a double-edged sword. We think regional anesthesia is safer. We think it's better for the patient, and that's why we do so much of it. In fact, one of the most recent audits of anesthetics for cesarean section at my hospital, conducted by Dr. Palanisamy, sitting here in the front row, showed that over the last 10 years, our rate of general anesthesia was roughly about 1%. Well, on one hand, this is good because we're doing a lot of regional anesthesia, but on the other hand, it's not good because we're not training our trainees to do general anesthesia for obstetrics. And in fact, it's not that uncommon that we have a fellow, not just a resident, but a fellow going through an entire year of training, advanced training in obstetric anesthesia, and do very few or sometimes even no general anesthetics in a pregnant woman. Certainly our residents, who spend only a couple of months rotating on the obstetric anesthesia service, may very commonly do all their obstetric anesthesia training as a resident and never do a general anesthetic in an obstetric patient. So we need to address this issue. One of the ways is with simulator training. Another way is maybe we should be doing more general anesthesia in certain types of cases where we think it's appropriate. One specific one, and then I'll stop, is you heard me mention in my talk earlier about anesthesia delay. Many times trainees are so ingrained to only do regional anesthesia for obstetrics that they just can't change their mind and do a general anesthetic even when it's indicated. They keep trying that spinal, they keep trying the spinal, they keep trying the spinal, producing anesthetic delay. And eventually you have to realize you're not going to get that spinal and you've got to do a general anesthetic. And maybe a quicker conversion to that would, number one, be good for training, and number two, be better for improving liability and maternal morbidity and neonatal morbidity by not delaying cases that shouldn't be delayed. So thank you. A superb question.
Can I add to that something?
Yeah, please.
Simulation fills countries like India with terrific dread, because most simulators cost something of the order of 2,250 lakh rupees. You know, that's a big expense, basically. But remember that you can do exactly the same using your own staff and using very simple training simulators that cost a few dollars. So what I'm saying is, that for example, in Indonesia, we've now rolled out for 8 years in a row a system called prompts, where you get your labor and delivery staff on a particular day, say a fifth of them, to go off and do a simulator session on shoulder dystocia, on massive hemorrhage, on preeclampsia, on a fitting patient, and so on, which costs absolutely nothing. A number of prompts you require is very small. And also, the staff themselves can act as the patient, they can act as somebody who's having a fit, you know, those sort of things. So basically, this need not be very expensive in hospital training, and it can be very effective in building team.
Right, so thank you. I think we have the last one. We are running out of time, and this would be important maybe for all of them. It's again to Stephen, but I would want William also to comment upon it. How do you both would deal with the hospital personnel if found to be repeatedly having near misses? Do you ask him to leave to the next hospital, next state, go back to India?
The answer is absolutely not. In fact, near misses in many ways need to be de-identified entirely, because otherwise people will not report. So even the national system, the ACEs and the AIMS, are completely de-identified, both as regards to patients and as regards to the operator himself or herself. Even the directors of units must not know who of the staff are contributing these near-miss reports. Because I think it's very important that when we go to morbidity and mortality meeting within our own departments, that they're initially de-identified. It's all right for that staff member to then get up and say, listen, this is one of mine, let me tell you what happened. But I think it is very, very important that all reporting systems of this sort are completely de-identified. And even in the mortality cases, one of the reasons why in 1986 we stopped for 2 years reporting these is that suddenly the reports from the confidential inquiry into deaths under anesthesia were threatened by the law courts that they might subpoena their papers and be able to get access to the decisions made by the committee. And so they stopped operating entirely. I think de-identification is incredibly important, and the courts must not get their hands on them, the lawyers must not get their hands on them, and the way that you would do this in Australia, and I'm not quite sure what the parallel in India is like, but what you would do in Australia is get something called privilege. Lawyers have privilege. What you tell your lawyer, if you tell somebody that you've murdered somebody else, the lawyer is under no obligation to go to court and say, this guy is guilty. I'm his lawyer, but he told me he killed the person. See, that's privilege. And that's the level of privilege you require for your own reporting systems.
What I'd like to add to that is the other perspective, which is how do you specifically deal with, and I think this maybe is what the question was addressing, a specific person that has had repeated near misses. How do you deal with that one particular person? What do you do? Well, obviously, you've got to extend the de-identification process, and they've got to be identified. Now, the key there is not publicly identified. We don't hang these people up to dry in a public fashion. But we have systems in our hospital where various committees are made for counseling, for reassurance, for analysis of these types of events and these types of people that may have had repeated issues. And we deal with it on a case-by-case basis. Now, sometimes it may be an age-related issue. We had one obstetrician in our hospital who was getting quite on in years and had a few near misses and was counseled that maybe this person should retire. And he did. And that was probably the appropriate thing. We sometimes have this in younger people where it's obviously not an age issue, but maybe an issue of inadequate training or just general inadequate skills. And certain types of things can be done there, such as remedial training. We've had residents have to repeat a year of residency. We have had faculty members who have had to have very specialized remedial training for various particular types of identified circumstances. So Dr. Gadd is correct about the de-identification in a general sense, but eventually you've got to deal with that particular person, and that person obviously needs to be identified, but in a confidential fashion to a small group of people who are trained in counseling and assessment of these types of issues, and then deal on a case-by-case basis with how to deal with that particular physician.
I think Bill is 100% correct there. We certainly need to have mechanisms in department to deal with all sorts of things like substance abuse, perhaps alcohol abuse, age issues, psychiatric illnesses, and so it goes on and on and on. And certainly as a head of department, I deal with these sort of things, not all the time, but certainly very frequently. And I think that's important. However, it is not the reporting system that should be used as the punitive tool. Those issues need to be away from the near misses reporting system. They need to be identified separately as being a particular individual who is a frequent flyer. And those frequent flyers need to be identified. We need to find a reason for them. And I think, unfortunately, in many situations, we've been seen as being far too punitive and not too supportive enough. The mechanism that you should put in place initially for those people is to, A, identify to them that there is a problem, and secondly, to also tell those people that, yes, this is a problem, and then try and find the remedy. Of course, if there is no remedy eventually, then they need to be retired. They need to go to the medical board. They need to be deregistered if necessary.
Thank you, sir.
But not using the reporting system.
Thank you very much.
Obstetric audits have had a profound influence on shaping obstetric anesthesia practice. But the significant problem in our developing countries are that extrapolation of audits which have been conducted in developed countries face stiff barriers when they are implicated in our countries in terms of differences in patient outcome, quality indicators, and complications which occur which are specific to our patient population. India is sadly lacking in audits, and the message which goes out from both of them is that we need to be very serious about conducting audits in our country. Because the Western counterparts are looking at maternal morbidity at present, while we are still grappling with maternal mortality. Thank you very much.
Thank you.